Yes, we will go ahead and get started. Welcome, everybody. Good morning. Thank you for joining us on our session on navigating migration and trauma-informed emergency department care. We're going to be citing some disparities and social factors in pediatric migrant patients. My name is Tatenda, and my wonderful co-presenters are Dr. Laura Jacknick as well as Dr. Colleen Lawrence. So we don't have any disclosures to make for our presentation. This is a list of our learning objectives. You can take a look at the slides in the SAEM app. I'm not going to take the time away from our presentation to read them all. So we're going to start with an audience poll. So we just want to get a better sense of where everybody is at. So with the first question, how familiar are you with immigration populations in your communities? So raise your hand if you feel like you are very familiar with immigration populations. Either you're working directly with them, or maybe you have some active engagement in some of the immigration policy or advocacy organizations in your community. Okay. All right. How about if you feel like you're somewhat familiar, meaning you have general knowledge or you get a little bit of exposure through personal life or work maybe? Okay. And raise your hand if you feel like you're not that familiar, meaning you barely interact with any immigrants in your communities. Oh, all right. Now, the second question we'd like to ask is, how familiar are you with your federal and state policies when it comes to immigration policies, especially around children? So raise your hand if you feel like you are somewhat or highly familiar with those policies. All right. And raise your hand if you feel like you're not that familiar. You may not keep up with regular policy updates, but you're aware? Okay. Well, thank you all for your participation. Our goal by the end of the session is that you feel a little bit more confident and better equipped with some of the federal and state policies that you should know about immigration care, as well as some of the available resources that are there to support the care of immigration populations, especially children. So we're going to dive into demographics. So today we're going to be reviewing data on children who have migrated to the U.S., as well as children who are born into born in the U.S. to immigrant families. So this slide looks at children in U.S. immigrant families over the past 3 decades, and it's really nice because it shows you the growing significance of children that are coming from immigrant families. As you can see, in 1990, they made up a small portion of the U.S. child population, and then by 2023, that number had grown substantially. So as you can see with the pie charts, the green segments represents children who were born into at least one immigrant parent, and you can see the significant change that has come over time. So currently, about 18 million children in the U.S., or 1 in 4, live in an immigrant family. So this is especially important because it's worth noting that 86% of these children were born in the United States, meaning that the vast majority are U.S. citizens. So the shifts highlight the major importance of having inclusive as well as equitable policies that support children regardless of their parental immigration status. Now, stepping back into global context, the United Nations High Commissioner of Refugees reported that 114 million people were forcibly displaced worldwide by the year of 2023, and this number had grown substantially for children who were displaced in the most recent years. So the same data source reported that between 2018 and 2023, over 2 million children were born as refugees. These trends continue to reflect a significant demographic shift in both U.S. as well as globally when it comes to our immigrant child populations. And it also highlights the growing presence of unique needs for immigrant, migrant, and refugee children while reinforcing the urgent need for culturally responsive, trauma-informed, and equitable pediatric care and policies. So this bar chart represents a visual representation of the evolution of U.S. immigrant population by region of birth over the last 6 decades. We're looking at the years from 1960 to 2023. So in 1960, as you can see, the vast majority of U.S. immigrants were born in Europe, and this accounted for over 70% of foreign-born populations. However, the distribution had shifted drastically over time due to U.S. immigration and refugee laws, increasing U.S. economic and military involvement in other global regions, and rising political and economic instability in key sending countries. By 2023, Latin America and Asia had now dominated the immigration population. The share of immigrants that you can see that came from Africa had also grown steadily, although it remained smaller than that of the Asia and the Americas. When we look at European-born immigrants, they had made up a smaller portion of the total, which was a significant reversal from earlier decades. So these shifts reflect a broad realignment of global migration patterns and how global and domestic policies can shape who migrates to the U.S. So when we talk about unaccompanied children released to sponsors by state and county, this slide highlights the increasing numbers of unaccompanied children arriving at the U.S. and Mexican border and are being released to sponsors across the U.S. over the past decade. Since 2011, there's been a substantial growth of the number of children arriving without a parent or legal guardian. And once these children are encountered at the border by U.S. Customs and also Border Protection, they're then referred to the Office of Refugee Resettlement. And the Office of Refugee Resettlement is then responsible for placing these children in care settings, identifying potential sponsors, as well as overseeing a screening and release process for them to ensure their safety while they wait for immigration proceedings. Now, the map and graph shows the distribution by state and county for the children released and sponsors. As you can see, the dark regions states like Texas, California, and Florida, they have consistently had a high record of number of children being released in their states. The bar graph below illustrates annual totals of unaccompanied children released to sponsors from the year of 2014 through 2024. And these, as you can see, there is an ongoing shift in the global migration patterns and increasing pressures at the U.S. southern border. So when we talk about the emergency department utilization and healthcare challenges, it's been found that pediatric migrant patients are 2.2 times more likely to use emergency department services compared to U.S.-born children. Some of the reasons they come to the emergency department include issues with malnutrition, dehydration, as well as vaccine-preventable diseases such as measles or tuberculosis, as well as untreated chronic diseases such as diabetes or tuberculosis. So I'm going to turn it over to Dr. Lawrence to dive into our case discussion. Thank you. You're welcome.
Good morning. So before discussing social drivers of health and how they affect access to healthcare and utilization of healthcare, we're briefly going to kind of prime the rest of our conversation with a case with some questions to also consider throughout the rest of this session. So we have a 7-year-old Spanish-speaking female with unknown past medical history. She comes in with increased work of breathing as well as dry cough for the past 2 days. She's been taking an inhaler that she received at a border clinic a few months ago, but it hasn't been helping. She has no known sick contacts, and her mother is worried that her symptoms could be related to mold in her shelter. Otherwise, her review of systems is most notable for chest tightness, otherwise negative. Her vitals are as you see them: a little tachycardic, tachypnic to 34, and hypoxic to 92% on Rumer. Her exam is notable for increased work of breathing with diffuse, with accessory muscle use, speech in 4 to 5 word sentences, and then expiratory wheezing throughout, and an otherwise reassuring cardiac as well as heat exam. So I think for most of us, this is a pretty straightforward case of a moderate asthma exacerbation, and it's going to require some additional treatment as well as monitoring before we make an ultimate disposition decision. So again, as we continue throughout the rest of this presentation, I want you to think about how you would address the following questions in your own clinical context. So are there any other factors that might influence your diagnostic or treatment or disposition considerations, expand that differential beyond that of asthma? And then how might immigrant patients perceive certain aspects of our clinical care environment and practice? Moving on to a discussion of social drivers of health and access barriers, beginning with insurance coverage. So a 2023 analysis found that insurance coverage for children varies depending on their immigration status as well as that of their parents. Children with at least one non-citizen parent and non-citizen children had higher rates of uninsurance at 8% and 25% respectively. And this is likely due to enrollment barriers, including fear and confusion about the process, language barriers, and then eligibility restrictions for federally funded health coverage for, like Medicaid, as well as the Children's Health Insurance Program, or CHIP. And while this analysis didn't evaluate for any association between insurance coverage and healthcare utilization, one could easily see how parents may self-restrict whether they bring their child to an appointment or to an ED, depending on their insurance coverage. Insurance coverage for children in immigrant families also varies by state. So encouragingly, many states have taken up options to expand coverage for immigrant children. And as of January 2025, 37 states plus the District of Columbia covered lawfully residing immigrant children without the mandatory 5-year waiting period for Medicaid and CHIP. And then 14 states plus the District of Columbia, which is reflected in the map at right, provided comprehensive, fully funded state coverage for children irrespective of their immigration status. Unfortunately, the policies currently proposed by the Trump administration, including 1, ending birthright citizenship, and 2, reinitiating the public charge rule, which traditionally considers immigrants' use of certain public health benefits as grounds for inadmissibility for citizenship, in addition to the general anti-immigrant rhetoric, are likely to negatively affect immigrant insurance enrollment and healthcare utilization. And I say this because this is exactly what was observed during the first Trump administration, as we're going to see in the next study. So this was a retrospective cohort study published in Pediatrics in 2022. They evaluated rates of uninsurance and Medicaid enrollment for almost 3 million US children, focusing on the time period immediately before Trump was inaugurated, between 2015 to 2016, compared with the 2017 to 2019 period immediately after he was inaugurated. And they found that uninsurance rates for children from mixed status families significantly increased, and there was a simultaneous significant decrease in Medicaid enrollment after Trump's inauguration. So in the ED, this suggests that fewer pediatric immigrant patients are likely to have insurance coverage, which could then affect whether their parents decide to bring them in for care, and definitely will affect the available options for you at time of disposition in terms of resources. Other studies have also found significant clinical repercussions of the first Trump administration's anti-immigrant policies, not pictured here, but specifically newborn weight for babies born to immigrant mothers significantly declined, and there were fewer well-child visits for children in immigrant families after Trump was inaugurated. And while these studies can't demonstrate causality, there was a strong association. Employment, education, and community in the built environment are other commonly recognized social drivers of health, but I'm going to focus on just 2 others, so language proficiency as well as stigma, just to highlight some of the more common ones for immigrant families. We know that limited proficiency in a region's dominant language is linked with adverse health outcomes, reduced engagement, reduced safety, among other outcomes. And this is why the use of certified bilingual interpreters is a best practice in addition to being federal law. Unfortunately, we in medicine, kind of globally as well as in the ED, still fail to use certified bilingual interpreters as frequently as we should. I think all of us, even if you're sitting in this room, have seen or perhaps have, in your own practice, relied on a staff member who's fluent in a language but not a certified bilingual interpreter, or relied on your own kind of passable fluency in X language to kind of move through an encounter. But the result of these shortcuts, in the words of patients, is fear of being sick. This was a qualitative study of refugee mothers with limited English proficiency, and they found that a majority felt helpless, unsafe, and unable to trust the medical establishment due to communication barriers. And this is reflected in the quote at right. And when we fail to use certified bilingual interpreters in the ED and in other settings, this not only makes individuals feel unsafe and helpless, but it also impacts patient care and outcomes relevant to us in the ED. This was a systematic review of 33 studies from 2000 to 2023, and they found that pediatric LEP patients had fewer pain assessments, waited longer for analgesia, had more discrepancy in pain scores, had longer time to and reduced rates of treatment, had longer lengths of stay, more frequent postoperative ED visits, and fewer follow-up appointments. Lastly, as I referenced earlier, the anti-immigrant rhetoric and policies during the first Trump administration impacted parents' healthcare decision-making for their children when they came to the ED. This was a cross-sectional study of parents who brought their children to 2 EDs in California, and they found that 75% of undocumented Latinx families felt concerned about their child's safety because of statements made by the president, and 17% then felt as though this impacted their decision about whether to bring their child in for care. Ultimately, when children in immigrant families do seek care, where they go is obviously influenced by all the social drivers of health that we just mentioned, as well as what healthcare is available in proximity to them and what they qualify for based off of how they came into this country. The chart at left is just a small snapshot of the different ways that refugees and asylum seekers come into the U.S. Refugees they benefit from undergoing some medical screening before they leave their refugee camp, and then medical screening and a short course of medical care after they arrive in the States. Comparatively, asylum seekers don't have any established or guaranteed screening process or obvious entry point into the medical system. And this chart doesn't reflect all the other types of immigrants that we care for. So seasonal migrant workers, human trafficking victims, employees, students. All of these individuals come into the U.S. with very different, under very different environments, and thus have very different constraints with respect to their health care. And so ultimately, I want you to take away that immigrants are a heterogeneous group, and so where they seek care is going to be variable as well. It could include primary care or specialty immigrant and refugee clinics if they're lucky, but it could just as easily fall to border clinics, free clinics, street medicine providers, and us in the ED, as demonstrated by Tatenda's note earlier that pediatric immigrant children are 2.2 times more likely to come into the ED for care. Okay, and since we in the ED are just as likely to care for immigrant patients, I think it's helpful to have some guiding principles beyond those social drivers of health to kind of guide our work. And so for this, I would propose the concept of immigrant-informed care. And this builds upon the core principles of trauma-informed care. It describes a healthcare setting that has the knowledge and the resources to meet all these multifaceted needs of immigrant patients. Key features would include the use of certified bilingual interpreters consistently, but also training culturally sensitive and responsive clinicians, and then creating referral pathways for undocumented patients into primary care, and supporting policies that protect the psychological and physical safety of patients. And at this point, I'm going to hand it over to Dr. Janik.
Okay, so now we're going to talk a little bit about some specific policies and how they affect us in the emergency department. So there are a lot of federal policies. They are complicated. They are changing. Many of them have changed recently. This is not a comprehensive review of this. We're just going to touch on some that are most pertinent to kind of our work in the emergency department. So first, when we're going to talk about unaccompanied children. So when children arrive at the border without a parent or a guardian, they go into the care of the Office of Refugee Resettlement. And the ORR is required by law to provide food, shelter, medical care to those children until they're able to place them with a sponsor. And then they need to find a sponsor for them. These sponsors are usually family members. So they're usually kids who are coming unaccompanied, have a goal sort of family member in mind that they're trying to go be with. And so the government helps to identify those folks. They do have to be adults. They do have to be able to care for the children and to provide for their physical and mental well-being. They also have to pass a background check. They have to agree to get the child to immigration proceedings when their court date comes up. And then they also have to agree to get them to ICE should that court decide the child needs to be deported. So they need to help with the whole process. The Trump administration recently reinstituted some policies that allows ICE to access the ORR database of those children as well as their sponsors. And the agencies are also now requiring that everyone in the household of the sponsor needs to be fingerprinted. And so not just the sponsors themselves, but all adults in that household. So there's a lot of concern that that is going to reduce availability of sponsors because, as we've been mentioning, many of these households are mixed status. So you have some undocumented folks living with documented folks living with citizens. Also, amongst all the federal funding cuts that we're all very aware of here, there have been cuts to the attorneys that have been providing legal assistance for these undocumented children in court. So prior to the last 4 months, about half of undocumented kids would have legal representation when they go to immigration court, and half had no representation. And that's because these attorneys that were generally funded by the government and some by philanthropy to support these kids, now that funding is all gone. So we anticipate that going forward, there's going to be minimal legal representation for undocumented children, or for unaccompanied children. All right, and then now let's talk about family separation. So in the first Trump administration, there was a lot of attention to the separation of families at the southern border. After that situation, there was a task force that was established to reunite families that had been separated during that process. That task force remained in operation through the Trump administration, through the Biden administration, and was only just recently discontinued. It did not succeed in reuniting all of those families, by the way. So there are still families that had been separated that have not been reunited. Going forward, we anticipate that most of the family separation that's going to happen is going to be because of immigration enforcement within the interior of the United States. So there are a lot of mixed status families where you've got parents who are undocumented and children who are citizens, and those are the families that are going to experience separation. A little later in the presentation, we're going to have a link to family preparedness plans, which I would encourage you to take a look at. These are very sort of clearly thought out plans and guidance for families who are potentially going to be in this position that helps guide them through the decision-making process to think about what they would want to happen should that situation arise. Do they want their child to be deported with the parents? Do they want the child to stay in the United States? If they want the child to stay in the United States, then it also walks them through all the legal steps of transferring guardianship, making sure that all of the needs are met for that child so that somebody doesn't get deported on accident, for example. All right, then there's public charge. Public charge is a set of rules for two situations. One, if you're in the United States and you have documentation and you're applying for a green card, so you're applying to start the process towards citizenship. Or two, you're outside the United States and you're applying for a visa to enter the United States. So in those two processes, the government can do a determination to say, is it likely that you might become dependent on the government in the future? And they take certain things into account, and if they feel like you might be likely to be dependent on the government, they can decline either of those processes. So it doesn't apply to all situations, but it's certainly a couple key situations. And when there are changes to those rules, it can change the perception of a lot of immigrants around kind of whether or not they should access services. The most recent iteration of these rules are from 2022, and under this rule, healthcare programs, including Medicaid, housing, and food programs, are all safe to use, and they do not affect the government's determination of that. Thus far, the only changes that the Trump administration has made this time around has been to say that immigrants do not need to prove COVID vaccination status to enter the United States. And then there's DACA, and many people have heard of DACA, Deferred Action for Childhood Arrivals. This is a program that was instituted to give permission to work and study in the United States for kids who arrived as children. This has gone back and forth through the courts. The Trump administration has made it clear that they would like to discontinue the program, but it has been sort of in legal limbo over the years. It still exists, but just the thing to remember about DACA is that now most DACA recipients are between the ages of 26 and 43. They're young adults to mid-career professionals, so most of the DACA people you're going to know are going to be your colleagues at a conference like this. And then there's several other policies for specific groups of immigrants. So when you're thinking about what were the rules around the Afghan refugees or Ukrainian refugees or Haitian immigrants with temporary protected status, like every country often has its own sort of particular history and immigration rules that it has had as options, and it gets really complicated. So I encourage you to know what your primary immigration groups are in your communities, and then to look up and to kind of stay up to date on what the changes are for those communities. The USCIS website's the best place to do that, and that's uscis.gov. push this button. All right. So then going on to state and local policies, we sort of talked a little bit about health insurance, which is a big state-dependent phenomenon. But I'm going to focus on Immigration and Customs Enforcement, ICE, which is the police of immigration enforcement. So under the Secure Communities Program, ICE is automatically notified anytime someone is arrested in the United States for any reason. And then ICE can determine if that person is subject to deportation, and then they can decide if they want to go and find that person and then take them from jail into ICE custody. This actually leaves a lot of power in the hands of local law enforcement, because most of the time when someone is arrested, they're not actually in jail for a very long time, right? They'll come in, they'll get booked, they'll go through the process, and then they often get released relatively quickly. And so when people talk about sanctuary cities and sanctuary states, oftentimes they're talking about local governments that are generally not helping along that process, that will not hold people longer than they otherwise would in custody in order for ICE to show up, or that have other sort of pro-immigration policies. But there's no defined definition of what sanctuary city means, and it's actually quite heterogeneous across the country. The map here shows sort of a general gist of state policies that are more pro-immigrant, which would be green, versus more anti-immigrant, which would be purple. But there's a lot of different variables that kind of take that into account. On the other side of the spectrum is 287G agreements. So this is a mechanism by which local law enforcement can be they can do special training, and then they can be deputized as ICE officers. So a normal local police officer can become themselves an ICE officer and do both local law enforcement and ICE and immigration enforcement. Most local police departments don't do this because they feel that it interferes with community relations, but some do. And so I also strongly encourage you to be aware in your local community if there is a sheriff's department or a police department that has a 287G agreement that might affect the ways in which you are aware of the ways that immigration enforcement happens in your community. And then enforcement in hospitals, thinking about up until very recently, there were federal policies that prevented ICE from actually doing any enforcement activities in health centers and hospitals. That has been changed. Now it is allowed. And so local hospitals are kind of going through their own processes, trying to figure out how do we continue to do patient care and take care of our patients in this legal setting. And so I would encourage you to find out if your hospitals have those policies, and if they don't have those policies, I encourage you to help them make those policies. Every hospital, every healthcare center in the country should probably be aware that this is a potential phenomenon and come up with a plan for that setting. A few points that I want to kind of point out on that. One is that ICE cannot access private space to do immigration enforcement without a warrant. And so we advise that hospitals make very clear where the private spaces are for their patients and the patient families. So for example, emergency departments are generally private. They're behind closed doors. You have to go through security to get in almost all hospitals. But the waiting rooms is often a little bit more of a gray area. So if you want to like explicitly distinguish your waiting room area as a place only for patients and families that you have to still kind of walk through to get through, then you can just designate that a private space. The other one is that should an officer arrive, they're not allowed to kind of go into the spaces or do enforcement without a warrant. You are not trained, I presume, unless you're a lawyer, to read warrants or to understand if those are appropriate or they need to be followed. So you should the hospital policy should also have a designated law professional who can interpret and decide whether or not there is a warrant, whether or not it's valid, and what we need to do about that. And providers, as well as front desk staff, and everybody kind of needs to know who that person is and just how to call them in case this situation arises. And I think this is important for us as providers to kind of know that there's a plan, and it's also important so that we can communicate this to our patient population as well, so that they can know that we're not just, winging it, that we actually understand this and that we will do what we can to follow the law, but also to protect our patients and ourselves. And then finally, healthcare providers can refuse to provide information if there is not a warrant. So HIPAA still applies, right? All the usual privacy laws that apply to all patients still apply even if someone is an undocumented immigrant. And then finally, There are 2 states, Texas and Florida, that as of now are requiring hospitals to ask patients about their immigration status and to report aggregate amounts of uncompensated care provided to undocumented immigrants. Again, at the local level, this is highly variable because it really depends on how the hospital is going about doing this. The hospitals can ask, but the patients don't have to answer by law. And so the way in which that is communicated varies depending on how the hospital is doing their training. It depends on the frontline staff. It's usually registration that's asking, not us. And so there's a lot of variability within these states, and then there's a lot of other states that are looking at similar policies. So a couple of points I also wanted to highlight about local variation is thinking about local resources. So one thing to keep in mind if you're taking care of pediatric patients in the ED is that the public school system is often a huge touch point for resources for these families and these children. And this is because there is a long-standing Supreme Court precedent that states that all children, regardless of documentation status, have a right to K-12 education. And so undocumented children have a legal right in the United States to elementary and middle and high school education. And so because of that, it is often one of the ways in which these families can actually access resources. And public schools are very aware of this. So they often spend a lot of time kind of making sure that they're reaching these families and helping them connect to resources. That said, the rules around ICE enforcement have also recently changed, as with hospitals, where they used to not be able to do enforcement in schools. Those rules are gone. So now you can do ICE enforcement in schools, and schools are, like hospitals, trying to figure out all their own local policies around how to respond to that reality, both in terms of their children, as well as the parents who are dropping off their kids and picking them up from school. A number of state legislatures have introduced bills that would bar undocumented children from K-12 education, but as of now, none of those have passed or been upheld by the Supreme Court. And then finally, also just wanted to sort of point out that shelter systems are another good resource. We all know this when we take care of our low-income and under-resourced patients, that there's a particular concentration of case management and social workers at our shelter systems, and they often are very well versed in all the resources of the community. And so particularly if someone is unhoused, think about the shelter system as a potential resource for immigrant patients. Do note that most shelters will take patients regardless of immigration status, but some of them require ID to enter the shelter, and so that might be a barrier to some immigrant patients, and some of them might have their own individual policies around immigration status, so you need to check with your own local shelters to see what their policies are. Now we're going to do a little exercise. I know there's only a few of us in this room, but I think there's variability in kind of what we know about our immigration resources, so I encourage you, either right now or during the presentation, to think about or Google immigration resources in your town. And then I also want you to take out your phones and get this QR code. This is going to take you to find usahello.org. This is an app as well as a website that shows you a national map of immigration-related resources in the country. So have this available, use this, and check it out. I think that like most of the cities have a lot of different resources listed, some that are very specific to kind of legal resources, but it also has food, housing, and other things. And if you work in a rural area, however, you may not have many resources. I work in both a city and a small town, and the small town where I work has nothing, literally no resources available. So you need to think more creatively when you're in a more rural area, or if you're in a part of the country where these organizations do not exist, and think about your general resources, where your social workers are, where your shelters are. But also you might, for certain things like legal resources, you might need to refer people into an urban area to get those. And we'll take it back to Dr. Lawrence.
Okay, so we're going to next discuss approaches to clinical care for children in immigrant families and see how some of the resources that you may have just researched hold up depending on the clinical context. Starting out again with a quick poll. So take a moment, consider where you practice, and raise your hand if you ask additional questions if you know or suspect you're taking care of an immigrant patient. Okay. And then would anyone who raised their hand be willing to share any of the factors or specific considerations? Okay, no problem. Next to last session of the day. We're going to go through these, kind of some of these considerations, and they're also available through the American Academy of Pediatrics. They might include, the language that they primarily use. It could include countries that they've, kind of recently traversed, potentially. It could include, past medical history, vaccination history, whether they have a vaccination card, which, depending on how they left their country of origin, they may or may not have. And so the other question that I would encourage you to just kind of privately ponder is, how do you ask these kinds of questions in a way that makes a patient feel safe and not negatively targeted because of their immigration status? It's difficult. Briefly, we're going to talk about ideal care for children in immigrant families. Perfect world, children and their families would have access to comprehensive medical screening and care, and they'd be able to build a relationship with clinicians that allows them to trust them, so that the clinician can then ask sensitive questions about their migration history. They'd then be able to, kind of initiate appropriate follow-up screening and kind of establish care. And then right in print too small to read, so sorry about that, you can kind of see some of the American Academy of Pediatrics recommended considerations for screening immigrant children, which you can kind of check out on your own time. Either way, though, a lot of these considerations are hard to initiate in the ED. We know that we have limited space sometimes, limited privacy to ask some of these sensitive questions. We have limited time. We might not be able to build that rapport. And I think there's some question as to whether it actually aligns with our goal and our role in the ED. And then finally, I think, it's also just hard to know where to start sometimes in addressing the multifaceted, kind of both medical and social needs of these patients. And that could be why some of you guys are here today. So in light of these kind of constraints and kind of our role in the ED, I'm going to propose 2 rudimentary frameworks to kind of structure your evaluation of children in immigrant families, taking into account like a broader differential as well as some unique factors that affect disposition. This first framework is reflective of immigration as a continuum of experiences with different risk and exposures accumulating and evolving over time. So you can see in the first column, I want you to consider what prompted the patient to leave their country of origin in the first place. Was it volitional or forced? Did they experience human rights violations, persecution, violence, or armed conflict? Did they leave because of poverty or climate change and subsequent natural disaster? All of these are commonly described as push and pull factors that might compel a person to migrate and then have subsequent psychological as well as physical effects. Furthermore, I think we need to consider that patients may also have disrupted care or treatment for chronic medical conditions, potentially related to some of these push and pull factors, or they may have unreliable access to basic resources like safe water, sanitation, shelter, and food with subsequent malnutrition. Fast forwarding in time, those same factors that shaped health in the pre-migration period continue to affect patient health afterwards. And during migration, additional exposures and risk accumulate. These include increased exposure to infectious disease due to crowding, as well as inconsistent access to medical care and basic resources. Immigrants may also encounter new dangers in the form of physical and sexual violence, extortion, and physical hardships of their migration journeys. For any of you who have read about the Darien Gap, it's a frequently traversed migration path for central immigrants from Central and South America, and it's very dangerous. It has a very it's a densely forested area. It's very mountainous. It has frequent landslides, and then immigrants are also exposed to poisonous plants, animals, and then extreme elements along their journey. And then finally, looking at the third column, after arriving at their destination, immigrants may encounter new risk and inequities, and these include racism, discrimination, decreased employment and educational opportunities, and these obviously affect their health in transition as well. We can also consider patient complaints in terms of communicable and non-communicable disease transmission and the risk factors for each. As I've noted before, immigrants often have an increased risk of certain communicable diseases depending on their access to medical care as well as basic resources. And then with respect to non-communicable diseases, they may have those previously diagnosed conditions with disrupted care or treatment, or they may have undiagnosed psychological conditions due to the trauma of their migration process. So this is from the American Academy of Pediatrics, and they specify certain best practices in screening children and immigrant families, as I mentioned before. But as you look through this list, a lot of these are more consistent with something a PCP would order as opposed to something that we would order in the ED, where it's not necessarily related to a chief complaint or may not return in real time. Even though we're not likely to pursue this type of screening in all pediatric patients, I did want to share them just to highlight the different risk factors as well as clinical considerations that we need to consider for these patients. And then also demonstrate the importance that eventually we need to connect these patients to some type of PCP so that they can undergo this comprehensive screening. Here again are some additional screening and treatment recommendations by the AAP. They're a little bit more targeted to symptoms, exam, and exposure history. As you can see, we're not going to be ordering a schistosomiasis treatment presumptively for many patients in the ED. And we wouldn't do this unless, order many of these tests unless we're admitting the patient or unless they have rock solid follow-up. I do want to make note, though, that for these immigrants who may have had a traumatic migration history, there's a 10-item child trauma screen that's validated for children aged 6 to 17. But you really should coordinate with your behavioral health, psychiatry, and social work colleagues to ensure that there actually are resources available if you do this screening. You don't want to just blanket do the screening and then not have any referral pathways for them. And then finally, if you anticipate discharging a patient with any test pending, it's important to document and have a conversation with the patient and their family about reliable contact information. Many immigrants have phones, cell phones, but they may have limited coverage or credit. And so think about alternative ways that you can reach out to them. WhatsApp is very frequently used, obviously both by people who are citizens in the States as well as by immigrant patients coming. And so that can be an additional avenue for follow-up. And Dr. Janik is going to take us to the next step.
Thank you. All right, so we're just going to touch on a couple specific points about discharge planning. These are under-resourced and vulnerable populations, so we want to be particularly thoughtful about how we're thinking about where they're going after discharge. So as with all pediatric patients, we want to make sure there's a safe home for them to go to and that they have appropriate adult supervision. We want to think about resources that we're connecting them to, as we sort of talked about before. Think about and ask if they need housing, food, legal support, and also if there are immigrant group-specific community resources, those can be very helpful. So if there's a large diaspora in your town from a particular country, they will be able to find other folks who speak their language and are from where they're from, and it's both very good for their social well-being, and there's also a lot of local knowledge that comes in those groups about how they navigate the community. Also thinking about specific groups that might have particular needs like LGBTQ individuals or homelessness. And then I would also add that the degree to which your department can directly provide resources can be very helpful. So if you have a meds to beds program where you can physically give them the medication in the department, that might be very helpful if they don't have the means to pay for medication at a pharmacy. If you are able to give them a transportation voucher to wherever they're going, resources like that can be very helpful in these situations. For medications, if you're not going to give it to them directly, there are also apps like GoodRx. If you've not heard of GoodRx, I strongly recommend that you Google it. It is useful for immigrant patients and for non-immigrant patients alike. But it's basically a coupon program where you can look up and find discounted prices for medications and it'll be specific to particular pharmacies in your community. You can have them download GoodRx and look things up themselves, but you can also go do it on your computer, print out the coupon, and they can physically take that coupon to a pharmacy and get the discounted price for them. So very helpful resource. And then when we're thinking about the ever important primary care follow-up, particularly for pediatric patients, we want to think about where they can go. And as with everything, it depends on your insurance status. If they have insurance, great, you can go down those normal pathways. If they don't, which is the case for many recent immigrants and undocumented immigrants, then you need to think about places where they see uninsured people. And that is generally either free clinics or FQHCs, which are federally qualified health centers. This QR code, you can tell I like QR codes, gets you to a map of all the FQHCs in the country. So if you don't already know this off the top of your head, you should know what the FQHCs are in your community, because that's where you're going to always be sending your uninsured patients for follow-up, because they have federal funding that allows them to see patients on a sliding scale in terms of out-of-pocket payments, and they are able to see uninsured patients. And then finally, when we're talking about how we communicate with these folks to give them instructions for after discharge, we want to make sure that we're using an interpreter when we do the discharge process. Oftentimes, I will make a particular point to actually sit down with the interpreter and talk directly with the patient on discharge, rather than just send the nurse in and hope that they use an interpreter and say the right things. Like, I make a point to do it all myself because the communication is often much more tricky. And then also, you need to sometimes ask about literacy and ask in a sort of delicate way whether or not they have trouble with reading, because sometimes even if you write in their home language discharge instructions, they may not be able to read it. And so if that is the case, you can also think about or ask them if they'd like to record the audio of you giving discharge instructions with an interpreter, because most of them have phones, many of them have WhatsApp. They'll have a mechanism by which they can record the interpreter saying what you want them to say, and they can re-listen to that instead of having to read instructions. So just getting creative and thinking about the best ways to make sure that they're hearing and understanding the plan and are able to kind of follow up with that.
All right, so diving into the topic of advocacy and how we can improve care for our pediatric migrant patients. As clinicians, we know we play a vital role in ensuring safety and equitable care for our immigrant families. So we must always use a certified bilingual interpreter at bedside and also actively reinforce confidentiality. This is so important because it builds trust, especially when you're dealing with patients who have encountered severe trauma and are experiencing fear. Also, practice cultural humility and be aware of your local and also national resources available, including family preparedness plans as well. And as you can see on the screen, the QR code is a link that will take you directly to an example of the family preparedness plan that's been created by the Immigrant Legal Resource Center. And it's a step-by-step guide that you can use when you're on the floors to help you guide your care. And then also, it's so important, know your state's laws regarding immigration status. This really is important because it'll help you understand how to navigate care in your emergency departments. And then also understanding HIPAA protections. Generally, we are not required to release patient information unless you are legally compelled. And then finally, never record immigration status in medical records, and also be cautious of what's visible in public areas. In your hospitals and communities, try to create a safe environment that is welcoming to all immigrant patients. And it's really important to have policies, protocols, and training for your staff on hand on how to properly deal with law enforcement, as well as warrant procedures, and also making sure that they understand legal protections and patient rights. And then, if possible, providing regular training on culturally competent and privacy on how to care for immigrant patients to support respectful, informed, and legally sound care is very important. And then also find ways to build trust. This can be done in simple ways, such as having affirming signage and clear boundaries between what's public versus private in your hospitals, just to help reduce some of the anxiety and fear that some of these immigrant patients may be experiencing. And then doing our best to include immigrant voices in patient advocacy councils, just to improve the overall patient-centered care. And then if possible, partnering up with immigrant-focused legal groups and organizations to strengthen both advocacy and also institutional preparedness. So to wrap our presentation up, we have some additional resources for you to use. The QR code is a link directly to SAEM's Immigration Advocacy Toolkit. It's a really good resource to use on hand if you ever need help or have additional questions. So I just want to thank everybody for your time today. We are now open to questions. Hi. That's okay.
How do you recommend going about asking or figuring out if the patient can't read, especially with the interpreter? Like, it seems easy to let them.
Yeah, I mean, I think a lot of it is with the interpreter. I like to sort of normalize it. So I will say, like, a lot of people have trouble reading these sorts of instructions. Would you like me to record this via audio as well as put it in writing? And so that way you're not making an assumption, but you're just kind of saying, like, here's another option. And if they're like, no, I'm fine, I can read it, great. And if they're like, yeah, that would be great, then they don't even have to tell you whether or not they have, you know, what their level of literacy is. They can just do it, you know. Oh, sorry, do you want?
Any other questions, comments, concerns? All right.
Thank you guys.
Thank you.
Appreciate it.